I'm Mandana Khalili, Professor of Medicine and Director of the UCSF Research Coordinating Center's Investigator Development Unit of the NIMHD Health Excellence Action Network. I'd like to welcome you to our monthly training webinar today. And we are honored actually to have our Dr. Elbert Huang speak to us on how the decision sciences and health economics methods are critical to addressing the epidemic of multiple chronic conditions. Dr. Huang is a professor of medicine and public health sciences and director of the Center for Chronic Disease Research and Policy at the University of Chicago. He's a clinical investigator who has made significant contributions in patient-oriented diabetes translational and policy research. And his research has provided the theoretical evidence-based foundations for the concept of personalizing diabetes care and treatment in older people. We are so appreciative and happy to have him here. During his presentation, please do not hesitate to ask questions through the chat function, and Dr. Huang will be happy to address questions as they come along the way. Also, please don't hesitate to do so at the end of the presentation, but we will have ample time for addressing questions in person as well. Dr. Huang, welcome, and we look forward to your presentation.
Thank you, Dr. Khalili. I really appreciate the opportunity. Let me see if I can. All right. Can all of you see that?
Yep.
Yes, we can.
Almost
All
there.
right.
I think that's presenter view. There you are.
Yeah, there we
Thank
go.
you so much.
Great. So here's the roadmap for today's talk. I'll be just briefly talking about the motivation for, why the decision sciences and health economics matter. For those of you who are, developing, studying different kinds of interventions to either prevent or mitigate the consequences of chronic diseases. And I'll do a very brief, and I hope I don't insult anybody, but I'm going to give you a very brief primer around what are the basics of decision analysis. And similarly, I'm going to provide a very brief introduction to health economics tools that we have available to us, including cost-benefit analysis, cost-effectiveness, cost-utility analysis. I'll explain how all this alphabet soup of methods are related to each other. Again, the introduction I'm going to give is really inadequate for actually carrying out any of these studies, and it actually requires formal coursework and actually probably mentored training. And then I want to provide you with hopefully some inspiration for how these health economic analyses can influence policy decisions related to chronic diseases. And they're all studies that I've been involved with. If I can, hopefully one of the messages, if I can do it, you can do it too. So this is all of you, I think, may already have this embedded in your minds already, but the United States is an outlier in terms of the amount of spending we devote to healthcare compared to most other developed countries. So here is on the x-axis is the gross domestic product per capita. In the United States is around 80,000. But what's really amazing is our health spending per capita, which is closer to 14,000 per capita. And we just have outsized spending in healthcare compared to all these other developed countries that are listed here in this table. And that has been the case for decades. However, all of that money is somehow not producing great health outcomes. And I'm being very crude here, but I'm using the ultimate health outcome, life expectancy. And you can see that all those other countries that manage to spend less per capita have actually higher life expectancy than we do. And life expectancy for most comparable countries is actually approaching 83 years of age. In the United States, we are actually flatlining. And actually for a period in the 2020s, we actually had a dip in life expectancy. I think this is around the COVID-19 pandemic. So clearly something is wrong. And some of this is attributable to chronic diseases in the United States. So in any case, this is the motivation for why we need to look at costs and why we need to look at health outcomes for any kind of intervention that we develop. So let me now we're back to graduate school, and we're going to talk about decision analysis. So this is a very now what I'm going to argue to you is that decision analysis can be just an amazing clarifying framework for thinking about any kind of scientific question. So it's an approach to analyzing. We're all making decisions as individuals, but organizations make decisions, nations make decisions, and we're making decisions under uncertainty. Decision analysis has been a tool that has helped us make all kinds of decisions, like when to screen, should we screen for HIV routinely? What are the ideal cholesterol targets? There's a long history of decision analysis that actually became really, really popular after World War II. And decision analysis is the foundation for health economic evaluations. And so here I'm gonna walk you through a very basic decision tree. And so this is a big moment for you, special if you haven't done this before. What the tree does is it requires you to enumerate a mutually exclusive and exhaustive set of possibilities. So what are we choosing between? And it forces you to say out loud, what is it we're choosing between? And then given each policy or treatment choice, you then have to develop a path of the tree that is comprised of probabilities of subsequent events. If you choose policy A, policy B, what are the probabilities of events that happen? And the tree also forces you to articulate what are the outcomes, what are the payoffs that actually matter for the decision. So in a decision tree, there's a very standardized way of writing out a tree. So we begin with a decision node, which is always a square. Then there are a whole series of, as the tree has branches, it's comprised of many chance nodes, and they're always represented as circles. And the sequence is always from left to right. There's probabilities at each chance node, and then the path probabilities are joint probabilities. And then at the end of the tree are triangles that represent the payoffs. So to mathematically solve these trees, you average out from right. You build the tree from left to right, but you solve the tree from right to left, basically averaging out the outcomes, the probabilities, and then folding the tree backward to ultimately arrive at your solution. So this is an extremely quantitative approach to making decisions. Some people joke about, this is how I decided who to marry, something like that. But obviously decisions aren't always quantitative. But when they are quantitative, it can be quite valuable. So let's imagine you're the chief financial officer for a fictitious county like Chef County. I happen to be in Cook County. That's where the joke is. And you're responsible for the financial oversight of the county government. And let's say you have a pension fund of $200 million. And let's say you have to look at outcomes at 10 years from now. So here are your choices. You need to decide how to allocate this money. So you have a choice between two different investment options. One is to invest the $200 million in a savings account with a 5% return. Actually, that's pretty good. Or you could invest in the stock market. But in the stock market, there's quite a bit of uncertainty. There's a 30% chance of you doing very well with a 50% return. There's a 40% chance of doing reasonably well with a 20% return. And then you have a 30% chance of doing very poorly with a 50% loss of that $200 million. So this is what the tree looks like when you write it out, and there's existing software like programs like Triage, where you can build these trees and have the software solve the math for you. So in this case, you see the decision node the square. You see the chance node here. There was only one chance I expressed to you, high yield, moderate yield, or a loss, and then the savings account. And you see the payoffs on the far right, and this is just the financial payoff of each of the potential events, futures, potential futures. Now, the funny thing is, of course, we only live one one life. This 10 years will only play off one time. But in decision analysis, you can actually imagine multiple futures. And this is actually solving the tree. So I didn't get to, I should have done more audience participation, but it turns out the right answer, at least based on this decision tree, is to invest the money in the stock market. Because overall, that it will you'll get $216 million at the end versus 210 million at if you invest in the savings account. So do just to stop here, what's the downside of what are the potential problems with this way of making a decision? Gretchen,
Edwin? Yeah. Oh, sorry. Oh, go ahead. Go ahead. Mhm.
Oh,
what
well,
do you think, Gretchen?
you need to take into account people's comfort with risk.
Yes, excellent. Any other problems with this way of doing things?
Highly dependent on your probability assessments. The accuracy of those is a big issue.
That's right. So you guys are great. So yeah, you've highlighted the problems. The underlying inputs could be problematic. But yes, and actually, Gretchen, you highlighted that this decision ultimately is affected by people's comfort with it actually is the ultimate right decision is dependent on a person's individual preferences. So preferences, you'll hear this repeatedly, matter a lot in the decision sciences, and there's different ways of weighting preferences, and there's a lot of debate about whose preferences matter. All right. So that was great. Okay, so anyways, so this is the most basic of decision trees that you could imagine. So I'm going to, so this, I've sort of told you that decision analysis is the basis for a lot of other health economic techniques like cost benefit, cost effectiveness, and cost utility analysis. And it's actually due to the fact that, at least in chronic diseases, we frequently have to forecast the future. So I'll show you in subsequent slides examples of much more complicated decision trees that take on different forms, in particular the Markov state models. But let me just boil down to also sort of talk about these health economic tools. These are different ways of accounting for both costs and health outcomes. Remember, I started with the two slides showing you that we have rising costs but poor health outcomes. These economic analyses allow you to both look at costs and the health outcomes at the same time, but they're mathematically different. They are mathematically related, though. So in cost-benefit analysis, what you do is you actually identify the policy option that maximizes net benefits. The key thing is that both the benefits and costs are all expressed in dollars. So health outcomes, like how long you live, the quality of your life, all has to be transformed into a dollar. And that allows for an overall analysis that just spits out a dollar value. And then I'll show you later how these are interrelated. In cost effectiveness analysis, you're trying to identify the policy option that maximizes health subject to a budget limit. If you had only $1 left to spend on healthcare, what would it be on? And that's the kind of question that cost effectiveness analysis answers. Cost utility analysis is a relative of cost effectiveness analysis, but in this case, the health outcome is specified as a health state utility. And then cost minimization analysis is a situation where the health outcomes are the same between two options, but you're just trying to identify the one that saves the most money. So mathematically, this is what each of these types of analyses represents. So in cost-benefit analysis, as I told you, it's the benefit of option 2 minus the cost of option 2, and you're comparing it to the other policy options, benefit versus cost difference. Cost effectiveness analysis and cost utility analysis are both ratios where the differences in costs are in the numerator and the differences in outcomes are in the denominator. And in cost minimization, you're just looking at costs, assuming that basically the outcomes are equivalent for the two options. And in cost utility analysis, we express the health outcome in terms of quality adjusted life years. This is the most widely used approach across the globe in terms of health technology assessment. So in cost effectiveness analysis and cost utility analysis, you have to remember that you're always comparing two things. You're not just looking at one thing. So it's the question is, relative to some baseline, usually usual care, what are the extra costs? What are the differences in health outcomes? And that generates this ratio, which we call an incremental cost effectiveness ratio. The incremental cost effectiveness ratio lands somewhere on this thing we call the cost effectiveness plane. And I'm going to use geographic language here. This is the northeast quadrant. This is the northwest quadrant. This is the southwest quadrant. This is the southeast quadrant. And each of the on the x-axis is the differences in health outcomes, and on the y-axis is the differences in costs. So you're sort of taking the ratio and then breaking it into its different constituent parts. But this is really important to understand how to interpret where a result of a cost effectiveness ratio comes out in terms of what it means. So I'll just talk through this for you. But in the northwest quadrant, would any of you pick something in the northwest quadrant? Just I wonder what your intuition is.
We have No by Gretchen.
Great. So basically, if something lands in this quadrant, you've actually increased costs and worsened people's health. So you would never choose that option. How about something landing in quadrant Y, in the southwest quadrant? Would you ever pick that? So you actually, in this case, have lowered costs, but you've worsened people's health. Would you ever pick that?
Not if I didn't have to.
Okay. There are some arguments in the literature that if it landed not too far from the unity, that it might be okay. You would harm people a little bit, but save a lot of money. How about a quadrant how about the southeast quadrant? What do people think?
Best one.
Yes. You have saved money and you've improved health. This is the dream of cost effectiveness analysis. But the unfortunate thing is it rarely happens. And then finally, what happens with most technologies is they end up, or new interventions, is they end up in the northeast quadrant. So they increase costs, but health is improved. And so that creates this tension. Is it worthwhile to spend additional money? So, and I'm going to show you, a lot of, I don't know where I have this. Oh, so one key thing about cost effectiveness analysis, and one thing I'm going to argue to all of you, is that you really should be thinking about whose perspective is represented in the analysis. In the base case analysis of cost effectiveness analysis, you're supposed to be using the societal perspective. And what that means is that you include all costs, all health benefits. You have to think about the patients, the providers. You have to think about caregivers and anyone else affected by a technology. The problem is, even though this is the recommended base case analysis, politically, it's the weakest perspective because no one actually represents a society. So the reason I have this graphic is that it just shows you the complexity of the healthcare system, and actually the public health and the world of public health. and each of the parties that are represented in this complicated picture have different views on what costs matter, what health outcomes matter. So just to call out some major players, including healthcare organizations, um, health insurance payers, I'll repeatedly talk about them, people who maintain standards, but obviously we also care about what community members think. And for them, out-of-pocket costs are very much top of mind right now, but they experience costs in a different way that affects the way they behave as well. So all of this just is to show you that there are many different perspectives you could adopt for a cost effectiveness analysis. So I am going to show you a few examples of where we've applied health economic analyses to problems related to multiple chronic conditions, and I'm going to try to help inspire you on how these different studies have actually had an impact. So I'm going to first talk to you about a study I did when I was much younger. It's essentially a forecasting study of how much diabetes will cost the country. A second paper is it's actually kind of funny how it happened, but actually blissfully easy, not actually a very complicated study, but had outsized impact on insulin prices. I'll show you something we just did earlier this year on GLP-1 RAs, on their cost effectiveness analysis. And then actually, this is a quite important study. This is actually a study about delivering care better and thinking about delivering care better as an intervention, not just a new drug, but delivering existing therapies. And then lastly, I'll show you a paper that used more econometric methods to study the value of federally qualified health centers. So this is a paper that utilized essentially a Markov simulation model of diabetes complications. But if you imagine each generation of people that are born being layered on top of each other across time, that's what this graphic shows. This is a forecast of what was expected to happen with changing populations and also with the evolution of with the natural history of diabetes over the course of time. What would happen to Medicare spending on diabetes from 2009 to 2034? And each of the colored sections represents a different generation. So this red group is the baby boomers. And so the projection includes both the natural history of disease, but also accounts for population dynamics. And we projected that costs of diabetes care for Medicare would triple from 2009 to 2034 based on what we knew about diabetes care in 2009. And actually, it was quite, this is what I would call kind of a public health pending disaster type paper, calling attention to the need to try to figure out ways to prevent diabetes and slow this down. How many of you think that we got this right? And it's actually we're only at 2025, and we projected out another 10 years beyond that. How many think we gotten this right?
Was it worse?
That's what I was thinking. It says,
So
I imagine it's a lot worse. I think it's worse.
the only thing we got right was the direction, but our timing is totally off. So this graphic, where we ended up at 170 something billion dollars by 2034, it's already happened. So this graphic is actually directionally correct, but we're off by a decade. Now, we also assumed that the obesity rate would remain at 30% in the United States. And I remember 20 something odd years ago being interviewed by a journalist about a paper that showed that 30% of Americans were obese. And I said, there's no possibility that it can go above that. And I have been totally wrong. It's up to 50%. And the other thing we didn't anticipate was the arrival of new drugs that would really transform diabetes care, but also cost much more than older therapies. So for a variety of reasons, we are totally wrong. But this paper by itself, even with conditions at the time in 2009, already alerted the public health world that we really need to do something to reverse course on diabetes prevention. And I think, unfortunately, despite a lot of efforts, including the creation of the National Diabetes Prevention Program, that we have really failed. Okay, so another thing that we did not anticipate, and this is a paper that that almost any of you could do right now if you had access to the Medical Expenditure Panel survey. So this was a study done using Medicare Expenditure Panel survey data, which collects data on costs of care for individuals, both out of medications, outpatient care, hospitalizations, and we discovered with the MEPS data that the spending on insulin for the average person tripled from 2002 to 2013. This was a simple research letter to JAMA, but this figure by itself alerted is one of several other studies that alerted the world that the drug companies were increasing the prices of insulin, even though the product had not changed. So this is insulin glargine in 2002 and the price of insulin glargine in 2013. All three major drug manufacturers had tripled or increased the price of insulin without much oversight from the U.S. But with these papers, this came to the attention of Congress, and there were lots of hearings by the House. And this is just a letter that went to the CEO of Eli Lilly at the time. And I'm just going to call out these sentences. Despite the fact that it has been available for decades, prices for insulin have skyrocketed in recent years, putting it out of reach for many patients. For instance, insulin's price nearly tripled between 2002 and 2013, and then nearly doubled again between 2012 and 2016. And so this called out this crisis, this public policy, public health crisis. And honestly, what really happened was, in addition to researchers making, like me, making these observations, there were patient activist groups that really called attention to this, as there were people with type 1 diabetes that were dying because they were trying to save money by using less insulin. And so this change in insulin pricing was a death sentence for some people with type 1 or many people with type 1 diabetes. So what's happened since is that there are now insulin out-of-pocket cost laws passed across multiple states. And then the federal government's Inflation Reduction Act, which was passed during the Biden administration, also puts a cap on insulin prices. And on top of that, all three manufacturers have voluntarily reduced the price of their insulin product. We can talk more about why they did that. Okay, moving on to another cost-effectiveness analysis of a drug. This is a series of papers. There are two papers we published earlier this spring using the DocM model, which I'm featuring here. It's an example of a Markov state model built by David Kim, who we were fortunate to recruit to University of Chicago 2 years ago. And again, each of these states represents a Markov state, and each of these arrows represents a transition probability. So in this case, this is a model that looks at people who are obese and then follows the history of whether or not they develop cardiovascular disease, diabetes, stroke, their first heart disease, their recurrent heart disease, revascularization, and in each given year, the patient is subjected to the risk of each of these events, but also death. If they survive, they go through this again and again in the model. And in this
Dr.
paper,
Huang,
yes.
I'm so sorry. There's a question regarding, can you define Markov state?
Oh, of course. So a Markov state is, I don't know if I can draw, if there's a whiteboard, but a Markov state transition model defines different ways of being. So the simplest model I could draw if I don't know how to do a whiteboard, but the simplest model is one where you have a state of being alive. Oh, thank you.
Let's see if this works. Are you able to use it?
Let me see. How do I get a pen?
Ooh, how do I give it to you?
Oh, here we
Share.
go. I
Ooh,
think
If you
thanks
click
so
on
much
the
for bearing
pen,
with me.
yeah, sorry.
voting. How do I do this?
Or perhaps if
Ah,
you
see.
open one from your side, open a whiteboard, I can close this one. Wait. Oh, here we go.
Oh, there you go.
What happened?
No, that's me.
Oh, that's oh.
Stuart, can you draw one? Alive, dead, sick. I'm expecting Stuart to know what a Markov state model is, but basically, yes, perfect. So a Markov state model is it defines the universe in terms of states, and then and basically people could only be in one state. Death is an absorbing state, and you'll have like different arrows showing the transitions. So this is he's doing the best job he can with Zoom.
Yeah.
It's actually not quite this, but I'm happy to do this at another. If I had the tools, I could do it. But let me. So
We
in any
also
case,
have a link in the chat.
the obesity model that I just showed you is a very complicated Markov statement. Actually, let me use that model and I can show you. Let's see here. So let's just stop. Let's just break this down. So in this case, let's just take this. This state is this is a Markov state, death. So it's a state of being, and it also happens to be an absorbing state. So once you end up in dead, you stay dead, unless you're in a vampire movie. Let's take stroke. This is actually a really good example. This is a Markov state. So people are transitioning into having a stroke, but then what happens afterwards? They can move on to these other states. So each of these arrows represents potential changes, movement from one state to another. So in this paper, we compared what's the cost and health outcome effects of different anti-obesity therapeutic options, including lifestyle change alone, naltrexone, bupropion, phentermine, topiramate, semaglutide, and tirzepatide. These are the semaglutide is the GLP-1 RA, and tirzepatide is the GIP GLP-1 RA that are all the rage. So I am kind of showing you the bottom line result on the cost effectiveness plane. And I'm only showing you the northeast quadrant because and so this is the result of the probabilistic sensitivity analysis. This cluster of green represents the outcome for semaglutide, tirzepatide's in yellow, and this is the cost effectiveness ratio, different cost effectiveness ratio thresholds: $100,000 per quality adjusted life years, 150,000, and then 200,000. And not surprisingly, tirzepatide and semaglutide are not cost effective based on this analysis. And however, the older drugs for anti-obesity are actually cost effective. And actually, in the case of naltrexone bupropion, it actually saves money. So what we did with this paper was also tell the drug companies how much their price would have to be reduced in order to be below these thresholds. We did this other analysis. Again, this is all led by a trainee, Jennifer Huang. She then did this analysis, which just focused on the budget, just the money part of the analysis, and did this on behalf of Medicare, because Medicare does not cover anti-obesity drugs, at least until recently. And the yellow line, and this is a very cold-hearted kind of look at costs, the kind of analysis that the Congressional Budget Office does. So in this case, the yellow line shows you the growth, and what we accounted for was new people taking the drug. We tried to guess how many people would stay on the drug long term. We accounted for savings due to being on the drugs due to improved health, but the blue shows you net spending. So despite the wonderful effects of these drugs, you can see that the price of the drug is a dominant factor. And actually, the United States is going to end up spending probably around 40 to 50 billion dollars extra in order to cover these drugs for Medicare beneficiaries. So again, in this paper, we used it as an opportunity to tell the drug companies or to telegraph to Medicare how much the drug prices would have to be reduced in order to break even. So I'm going to transition a little bit to talking about delivering care differently. And so I'm going to talk about the health centers, which have been a place that we have worked with quite a lot. The health centers were created by the Johnson administration as part of the war on poverty. It started as only 2 centers, one in Mound Bayou, Mississippi, one in Columbia Point in Boston. And now it's a program of over 1,300 something odd sites. These are the 2, Jack Geiger on the left, and then John Hatch on the right. These are they at the site of the Mound Bayou, Mississippi Health Center. Many of you may be working with health centers or in health centers. And this is the Columbia Point site in Boston, affiliated with Tufts. So we did an exercise where I just showed you 2 analyses looking at I just showed you the cost effectiveness of a new drug, but sometimes the question is not do we need to pay for a new drug? What about delivering care for existing therapies better? So the Health Disparities Collaborative was an effort across 1,000 of the centers in the late 90s that basically taught centers how to try to improve chronic disease management with quality improvement tools, the chronic care model, and learning sessions. They would actually meet together and learn from each other on how to deliver care better. This is the famous cartoon of the Plan, Do, Study, Act cycles. You just keep iterating and changing as a system to try to improve care. And the health disparities intervention also required a commitment of the CEO, these regional learning centers, regional learning sessions, and then they had these cluster coordinator support calls. This is all in the era before electronic health records were readily available. So if they had to look at quality of care, they had to pull charts to determine if quality of care improved. Again, what we were asked to do was, did the diabetes section of the Health Disparities Collaborative, was it cost effective to improve diabetes care? And this is a cartoon image of a diabetes simulation model that we used. So this is actually the bottom line result of this analysis, which is that the improvements brought about by the Health Disparities Collaborative actually was projected to reduce lifetime blindness, renal failure. It didn't change amputation. It would reduce heart disease. It would improve quality of life by about 0.4 quality adjusted life years, and it would increase costs. The bottom line cost effectiveness ratio was $33,000 per quality adjusted life year. This was not an evaluation of a new drug. It was an evaluation of using existing drugs and making sure that they were implemented. And this $33,000 per quality is a lot less than the tirzepatide cost effectiveness ratio I just showed you. So a separate study I'm going to show you is around health centers. And in this case, the health centers came to us and said, we're delivering primary care for really difficult populations, and we want to know if we are providing care that's of equal value or lower costs or higher costs for people who are on Medicaid, Medicare. And so what we did was an analysis using Medicaid claims data. We compared patients that preferentially used health centers versus those who went to hospital-based clinics or private clinics. That's what's shown here is physician offices, hospital, outpatient, and the referent in this case, and the arrow is the difference between the health center and these other practices. And what we found is that patients that went to health centers are less expensive. They actually use physician offices more. They actually use primary care more. They use less inpatient care. There was a little bit more emergency room use compared to physician office, but it was less than the hospital-based practice. This is all using Medicaid and Medicare claims data. And we actually looked at this pattern across all the states that we had available to us. And in general, health centers were a less expensive place to get primary care than in other primary care settings. So for whatever reason, they appear to be more efficient and have a more ambulatory care orientation. So I hope I'm happy to answer more questions about that. But bottom line is the first paper I showed you really was a call to action for a lot of people, and it was used to justify the formation of the National Diabetes Prevention Program. It did not, in the end, reverse kind of the trends that we see today, but it did lead to some action, but maybe not enough. The cost of care insulin price paper, which again was a simple letter using publicly available data, led to a lot of legislative action at the state level, federal, and the companies voluntarily reduced their prices. Now, don't think that they're doing this because they're being nice. They were transitioning to other drug products that they were also producing at the same time and did realize that they were not going to make that much money from insulin. The more recent paper I showed you on GLP-1 RAs, this is kind of crazy, but the Trump administration actually had contact with Jennifer and David throughout the summer, asking questions about our paper. And the Trump administration a few weeks ago announced that they were expanding Medicare Part D to cover anti-obesity drugs. And they negotiated lower, and they actually used prices very eerily similar to the ones that we used in our paper and in subsequent analyses when they negotiated with Sanofi, Novo Nordisk, and Eli Lilly. So we may have influenced the negotiations in that case. The cost effectiveness analysis paper on Health Disparities Collaborative, was at a time when quality improvement was a lot of health systems were balked at adopting quality improvement because they were worried about how much it would cost. But now quality improvement is really baked into it's really been absorbed by health system as part of routine care. And the analysis that I showed you using Medicaid claims was actually used to justify expansion of the health center program towards the tail end of the Biden administration. The health centers remain an incredible value, and they're the national backbone for primary care in the United States. So I want to convey these messages to you. How can you incorporate these methods? So the value of prevention, improved delivery, and new therapies, they can all be assessed with these tools that I've shown you. So whatever area you're in, I'm certain that you can leverage these tools. And if you're overwhelmed, start with one side of the ledger, something simple. Think about costs. You might have not thought about costs. What are the costs of the condition that you're interested in, or conditions? What are the costs of the intervention that you're studying? That the balance of the cost of the condition and the cost of the intervention ultimately are going to drive, whether or not something you're studying becomes adopted. Identify who your policy audience is. Who are you trying to persuade? What costs matter to them? And if you don't want to do this by yourself, collaborate with a health economist. All of you are, I think, have either virtually across geography, but maybe even in your own university, you have a health economist who can help you. So thank you for allowing me to share that with you, and I'm happy to answer any questions.
Thank you so much, Dr. Huang, for that amazing, outstanding presentation. Very, very helpful. The floor is open to questions. If anyone has any, please don't hesitate to raise your hand. We'll call upon you. Oh, here we go. Gretchen, go ahead.
Yeah, just kind of following up on the last point made there, Dr.
Gretchen,
Huang,
would you
about
mind
going-
introducing yourself as well?
Oh, sure. Yeah, I'm Gretchen Buchanan. I am in Minneapolis, Minnesota. at the Hennepin Healthcare Research Institute and University of Minnesota Medical Center. I research perinatal mental health and integrating behavioral and medical care in healthcare settings, and have a background as an implementation scientist. And curious if you have thoughts on how, or just kind of maybe describing more the field of health economics in terms of like if I was going to find somebody for a grant that that I'm doing a grant and I would be interested in having like an aim about cost effectiveness. Um, is there, do people kind of specialize on the different um, kind of areas that you talked about, the different types of analyses, or yeah, just like how would you recommend going about finding someone?
Uh, that is a good question, and I'm a little bit distracted because I literally just met somebody who is a health economist that studies your area. And she literally just presented to us on her simulation model of perinatal opioid use disorder treatment. Um,
Oh, okay.
Ashley Leach from Vanderbilt. Oh, so in any case, what happens is in any given area, there will be probably someone who specializes in the disease, and they may have actually already built. Now, the incentive for that faculty member or that academic, anyway, it's worth connecting with them and figuring out if they're willing to share or teach you about what they're doing. And so there's clusters of people that work in. So, for example, University of Chicago, if you have interests in obesity or diabetes, please reach out to me because we actually have a diabetes translation center, and we're actually supposed to help people with access to diabetes models and obesity. There's another cluster of people in Cornell that have in Boston with expertise in substance abuse modeling. Um, so each area of medicine has throughout the country, you'll find some group that typically that and if the area doesn't have dementia is another area. There's a lot of interest in modeling around dementia and aging. Um, but so yeah, you just have to ask around and but you'll probably find them and it takes an introduction to make that happen. But Ashley, I just saw Ashley Leach give a talk last week. So
That's
I also host a medical decision making workshop every month. And if you're interested, I can add you to our listserv. We talk about all kinds of things, and it has about 20 people 15 to 20 people attend per month.
that's
Uh,
awesome. My grant is actually about perinatal opioid use disorders, so
oh, that's
that's
Erie. Yeah, you should
completely
look her.
perfect.
Yeah, please look her up. Yes.
Yeah, I will. Thank you.
Yeah.
Fantastic. And I think we have a few minutes to potentially answer this question from Edwin. What's a good training plan for fellows wanting to get into health
Ah,
economics analysis?
okay. Very good idea. Important question. There is there's a society called the Society for Medical Decision Making, SMDM, um, and they actually have a fantastic short course every year where you can learn about all these methods. And they have a great annual meeting. It's actually a fairly small society, and so that's my go-to reference for people who want to do more training. And then, of course, at your local university, you should look to see if someone teaches this. Um, and uh, so yeah, that'd be my best reference.
Perfect. Edwin, what is the link you put in the, oh, just the
I
education.
I just
I
looked
got
up
it.
what Elbert said and found
Yeah,
the short course and their page on education, career, and tools for the Society for Medical
It's really
Decision. So,
it's really amazing and pretty low cost and fast way to learn methods very quickly.
great, thank you, because people are always
fantastic.
Oh yeah,
looking for
and then
short courses and summer seminars to
right.
add into
And
their.
Rochelle found
Yeah.
the substance abuse modeling group, Cherish, which has quite a lot of funding and regular meetings. I'm very impressed with them. So um, yeah, depending on the area, you'll breast cancer has its own world. Um, colon, there's modeling. Cancer has a number of different clusters of people that specialize in different disease cancers.
Absolutely. Thank you for that. Maybe if there's no other questions, I can ask you an additional one. It was
Yeah.
really fascinating to see the information shared, and thank you for doing that with regards to the cost effectiveness of the GLP-1s, which is the
Yes.
world we live in currently in many, many
Yes.
ways. So I'm a liver specialist, so within my world, that is also an incredibly useful drug to use now as an FDA indication for fat in the liver. And with
Yeah,
that in mind,
we don't have MASH in the model.
you don't have MASH in the bottle. That's right. It would have been great to see that actually. Dr. Hong, what are your thoughts about the changes that are anticipated to occur starting January for reduction of the costs that we think will happen with the administration? This is now self-pay in a way, but any thoughts about what would be the most reasonable level of costs that would be acceptable with respect to some of these chronic conditions and its management?
Are you referring to, can you
Yes, so
ask the
so
question
it's
a different way?
anticipated. Yeah, sorry.
Uh,
Just to clarify, it's
yeah.
anticipated that in the new year. Well, two things are anticipated. One is that the at least Medi-Cal or Medicaid will in our state, and I'm thinking probably throughout the country as well, are not going to be covering
Yes.
these medications unless it's for FDA indications, which are specific to, for example, MASH or diabetes, etc.
Right.
And then the second change is sort of the self-pay cost is going to hopefully reduce. We don't have that completely known yet, but the strategy being that it may sort of reduce to $350
I
a
see what you're
month kind of
asking.
thing.
I
I'm
see.
just wondering, what do you see in the future with looking at
I
the
see.
changes that are coming
For
and
the
how
for
do we
the
advocate for these things?
I see.
Yes,
And you're asking about the GLP-1s in particular, right?
yes, in
Well,
particular.
I mean, certainly the direction, the fact that that there's been this negotiation for the list price to come down, that means that the net, the more people will be using these drugs. And however, I suspect you'll still have this unequal uptake. Uptake of the drug will be probably will reach more people, but I think you'll still have challenges. I mean, if you're facing kind of food insecurity and the cost of these drugs, I mean, that's kind of I think that situation is actually going to happen more and more. And to me, the first principle would be to address the food insecurity before giving someone GLP-1. But so I think we're going to have probably some better access, but I think it remains to be seen what's going to happen over in terms of overall population health. I mean, one big question is, do these drugs basically help to solve the multiple chronic condition epidemic that we see? I'm actually quite skeptical that they will. So, for example, one simple example is there's in diabetes management, they're supposed to be reducing the use of insulin, for example. But I see lots of patients taking the drugs with insulin. So the insulin use hasn't gone away because they still have some insulin requiring part of their body. So I don't think this is the right way to solve a public health problem, but it is an amazing tool that will have public health consequences.
And you're absolutely right that lifestyle modification has to be absolutely a component, and that is critical. But I think there's some mechanisms of the drug that may be more
Yes.
direct mechanisms that also are potentially helpful in
Yes.
reducing chronic conditions. Um, okay, any other questions? Well, if not,
Did you
this
see the
was.
question about dementia? What groups work on dementia cost?
Oh, okay.
Thank you,
Yes.
Insha.
Yes. There is there's a group out of USC led by Dana Goldman, and I think they have a dementia model. Um, uh, but it's not as clear to me. Yeah, I don't know that world as well.
Great. Okay. Well, if there are no other questions, once again, Dr. Huang, thank you so much for that comprehensive and outstanding presentation. We really appreciate it.
Thank
And
you.
we look forward to working with you in the future as well.